Hello everyone, in this video we're going to talk about pathologies arising from the cornea that cause red eye. First off, we can have foreign body that gets stuck in the cornea and that can give you a red eye, and we remove this with a bit of local anaesthetic drops and remove the foreign body with a needle or cotton bud under slit lamp, and you may or may not need antibiotic ointment as well. It is to note that the red flags would be high velocity of foreign body that's hit the eye, assume that it's in the eye until proven otherwise. Things like hammering metal with a hammer, so metal on metal is the most serious, and that often presents in car mechanics, and that is usually, they might not even notice it, but there's a tiny piece of metal that's penetrated the eye. It's come in great velocity and really hot, but it can be very toxic to the retina if left inside the eye. Moving on, you can have corneal abrasion, in which case you examine the eye by staining the tear film, which is the most superficial layer of the cornea, as we discussed in the anatomy video, with a bit of fluorescein dye, and examine the eye under cobalt blue light, and the epithelial defect will be stained green. That is because the stain is on the basement membrane underneath the epithelium that's been rubbed off, and you manage this either conservatively or you may or may not need antibiotic drops. Chemical injury is an ocular emergency, and alkalis are worse than acids because they saponifies the lipid and that dissolves the cell membrane really quickly and further penetrates into the eye, whereas acids coagulates a protein and sometimes actually reduces the penetration of the acid. Mild burns can cause conjunctivitis, but more severe burns can cause the cornea to turn white because of vascular closure, which is followed by sloughing off of the dead epithelium. So we can check the pH using litmus paper, but that should never delay the management. So when you see a patient with possible chemical injury, then immediately flush the eye with 1 to 2 litres of saline before doing anything else, and use water if you don't have saline at the time. Further management includes sweeping of the fornices to remove any matter, G steroids, antibiotics, dilating drops of vitamin C. Recurrent erosions are caused when the basement membrane underneath the epithelium is disturbed and the epithelium becomes very easily rubbed off with very minimal friction, and it may follow previous abrasions like fingernail scratches or secondary to corneal dystrophy. Patients often complain of painful eye on waking in the morning because they're opening the eye over a dry cornea because of the epithelial breakdown during sleep. You'll examine the eye under the slit lamp, and that may show conjunctival injection or fresh or healing epithelial defects, and this is managed with lubricants, pad, debridement, and potentially laser therapy if severe. So lastly, we're going to talk about acute keratitis, which is an emergency. It is caused by microbial invasion of the cornea, causing inflammation and damage to the corneal epithelium, stroma, and endothelium. But you can also get non-infectious keratitis, which is rarer, such as peripheral ulcerative keratitis. So infectious keratitis-wise, you can get bacterial keratitis, which is the more serious form, and risk factors include contact lens wearers, or any ocular surface diseases like blepharitis. You can get viral causes like hepatic keratitis, where you get dendritic ulcers when you view the eye under slit lamp with a fluorescein stain, where you can see the beautiful branching due to the virus follows the sensory nerves of the cornea, which are fine and branching, and these need to be treated before it scars. You can get a disciform keratitis, which is the reinfection of herpes. Herpes normally stay dormant in the sensory ganglion, but if there's an immune reaction to the herpetic viral particles themselves, then they can cause deep stromal infection. Occasionally you can get adenoviral keratitis, which is the common cold virus, and that can cause tiny opacities of the cornea, which can affect vision, such as glare symptoms or halos around light at night. You may get conjunctivitis as well. Acanthamoeba keratitis is a protozoa in treated tap water, and it's extremely painful and can cause scarring, and the typical patient will be one who wears contact lens but with poor hygiene, or a farmer who can get waterborne infections. Symptoms include a red eye and reduced visual acuities because of corneal opacities. It can be very painful, but hepatic keratitis may be asymptomatic because herpes simplex can have some degree of numbing effect. One may have tears and lid edema due to inflammation and irritation, and often patients are photophobic because of the intraocular inflammation. In hepatic keratitis, we need to be careful of potentially raised intraocular pressure. We may see the typical skin lesions with vesicles and follow a dermatome, Under the slit lamp, as we said before, we can see the dendritic ulcers, and recurrence is really common in herpetic keratitis, so we may see some old stromal scars. In fungal keratitis, we often see multifocal corneal ulcer with feathery edges. And in acanthamoeba, we may see enlarged corneal nerves, and we want to do a scraping for microscopy culture and sensitivity, and we might want to do some cultures from contact lens cases as well. In bacterial keratitis, we can see hypopyon, which is white cells in the anterior chamber typically. We want to admit these patients, do swabs, scraping, and give intensive topical antibiotics and mydriatic drop. In low-risk patients, we can give some broad-spec antibiotics like polymyxin B or trimethoprim, or fluoroquinolones like moxifloxacin. In high-risk patients, we want to give tolbromycin or gentamicin with a cefazolin or vancomycin. We advise patients to stop wearing contact lenses during treatment and wear an eye shield if corneal thinning is present. In cases of herpes, we can give topical trifluoridine or ganciclovir or isiclovir, but in disciform keratitis, we would give oral isiclovir and prednisolone eye drops or G steroids, and if it's recurrent, then we might give prophylactic acyclovir. Just as a reminder, steroids will exacerbate any viral causes, so should never be used as a blind treatment of a red eye. In fungal causes, we can give topical or oral antifungals, and first line would typically be natamycin. In acanthamoeba, we give PHMB eye drops, which is short for polyhexamethylene biguanide. Propenamide and neomycin can also be used. For symptom relief, we can give analgesia and cycloplegics like atropine, which will help with the photophobia and anterior chamber reaction. Any non-infectious causes will need opthal referral for steroids and probably immunomodulating treatment. Keratitis needs prompt treatment because of potentially serious complications like corneal scarring, perforation, endophthalmitis, and blindness.